Welcome to the deep dive. Today, we're cracking the code on a condition that really challenges the immune system, the nervous system, and the doctors trying to piece it all together. Multiple sclerosis, or MS.
It really is, arguably one of the most complex neurological diagnoses out there, and our source material, thankfully, gives us a pretty brilliant roadmap.
So what's our mission today?
Well, the goal is to quickly synthesize the key diagnostic signposts, those unique symptoms, and maybe touch on the complex, high-stakes treatment landscape for MS.
Okay, let's ground ourselves. Basic definition first. MS is an autoimmune condition, right? Your immune system essentially goes rogue, attacks the central nervous system, brain, spinal cord.
Exactly. It causes inflammation and destroys that protective myelin sheath around the nerves. And the official diagnosis, it really hinges on this core idea. The demyelinating lesions have to be separated or disseminated in both space and time.
Disseminated in space and time. That sounds crucial.
Yeah. It's absolutely the central pillar. The whole diagnostic journey revolves around proving that. Now, thinking about who gets it, we generally see this in biological females, often presenting in, say, early adulthood.
Right, that's a key demographic. And risk factors. What makes someone more likely to develop MS?
Our sources are pretty consistent here. Prior infection with Epstein-Barr virus seems to be a major link.
Interesting.
Yeah, and then you've got environmental factors, low vitamin D, smoking tobacco, and this distinct geographic pattern. The risk goes up the further you live from the equator. High latitudes.
So higher latitudes, lower vitamin D, maybe.
Yeah.
The disease starts, but you said lesions can be anywhere in the CNS, so the first symptoms must be all over the place.
Totally unpredictable, often. That
Yeah.
first attack, the thing that finally makes someone see a doctor, it's usually some unexplained neurological symptom that comes on over hours or days. And crucially, it has to last at least 24 hours.
And the specific symptom depends on where the attack happens.
Precisely. So you might see optic neuritis, that's vision loss, often with painful eye movements. Or double vision, slurred speech, maybe numbness or weakness in the face or limbs. Or balance problems, vertigo. It's a huge list.
Wow, okay. If the symptoms are that broad, how do clinicians even begin to suspect MS specifically? This is where it gets interesting, right? These subtle, specific signs.
Yes. The flashing signposts, as you called them. These are the clinical giveaways that scream MS, potentially. First one, trigeminal neuralgia.
Which is usually seen in older adults.
Right, but when you see this intense, sharp, shooting facial pain, often triggered by just light touch in a young adult, that's highly suggestive of an MS lesion in the brainstem affecting those nerves.
Okay, what else? You mentioned things related to temperature and movement. Let's talk Elithoff phenomenon, the heat warning.
This is really distinctive. It's a temporary worsening of neurological symptoms when the body temperature goes up.
Like on a hot day or exercise.
Or the classic example, a hot shower. What happens is the heat further messes with the signal conduction in those already damaged demyelinated nerves. It slows things down or blocks the signals. It's very specific to demyelination.
And then the really dramatic one, Lermit sign, the shocking sensation.
Yeah, this one's quite something. The patient bends their neck forward and zap. They get this sudden electric shock feeling shooting down their spine, maybe into their arms or legs.
What causes that?
It points to a demyelinating lesion in the cervical spinal cord. Bending the neck stretches that sensitive, damaged area and triggers this sort of electrical misfire. Very specific clue.
So besides these sensory and motor red flags, what else are we listening for in the patient's story?
Oh, definitely the non-motor symptoms. They're critical. Things like profound fatigue, just exhaustion that's way out of proportion. Depression is common too.
And autonomic issues.
Yes. Problems with bladder control, bowel function, even erectile dysfunction, all stemming from CNS damage. And crucially important, you need to make sure there's no fever or other signs suggesting a systemic infection. That points away from MS.
Okay. So the history gives us strong suspicions. Where does the physical exam confirm things? You said findings are variable, but the eye tests, those can be pretty definitive.
Absolutely. The ocular findings can provide really strong, immediate evidence. The big one is the relative afferent pupillary defect, or RAPD. You might also hear it called the Marcus Gunn pupil.
And that points directly to optic neuritis, inflammation of the optic nerve.
It's the physical signature of it, yes.
Can you walk us through that swinging flashlight test? How does that work?
Okay, so normally you shine a light in one eye, and both pupils constrict equally, right? The light signal goes in one eye, that's the afferent pathway, the optic nerve. goes to the brainstem, and signals go out to both eyes to constrict. That's the efferent pathway, the oculomotor nerve.
Makes sense.
Now, in someone with optic neuritis, that optic nerve, the afferent path carrying the signal in, is damaged. So, when the doctor swings the flashlight from the healthy eye over to the affected eye.
The signal coming from the affected eye is weaker, like turning down the volume.
Exactly like that. Because that incoming signal is weaker, the brain gets less instruction to constrict the pupils. So, paradoxically, as the light hits the bad eye, both pupils actually appear to dilate slightly compared to when the light was on the good eye.
Wow. So the dilation is the key sign.
That paradoxical dilation is the RAPD. It tells you the problem is in the nerve bringing the signal in. And this often goes along with the patient reporting decreased vision and specifically that red colors look faded or washed out in that eye, red desaturation.
Okay, that's one key eye finding. The other one you mentioned was internuclear ophthalmoplegia, INO. Sounds complex.
It does, but it points to a very specific spot. It's caused by a lesion damaging the medial longitudinal fasciculus, the MLF.
The MLF, what does that do?
Think of it like the brainstem's coordination center for eye movements. It's the cable that connects the nerve controlling outward eye movement, cranial nerve 6, with the nerve controlling inward eye movement, cranial nerve 3 for the other eye. It makes sure they work together when you look side to side.
Like a communication cable. So if that cable gets damaged by an MS lesion, what happens when the patient looks sideways?
Okay, let's say they look to the left. The left eye turns outwards, abducts. Okay, but the right eye, which is supposed to turn inwards towards the nose, adduct, it lags. It doesn't move fully, or maybe not at all.
Impaired adduction.
Right, and often the eye that is moving outward, the abducting eye, will have nystagmus, that fine, shaky movement. Seeing that combination, the failure of one eye to adduct properly, plus nystagmus in the other abducting eye, that's the classic sign of INO, pointing straight to an MLF lesion. Very common in MS.
Got it. And beyond the eyes, we might find other signs of sort of upper motor neuron damage.
Yeah, things like dysarthria, which is slurred speech, spasticity or stiffness in the limbs, hyperreflexia, overactive reflexes, maybe a positive Babinski sign where the toes fan up and out when you stroke the bottom of the foot, and ataxia, problems with coordination in the limbs or with walking.
Okay, so the exam builds a strong case. Then we bring in the heavy hitters, imaging, and CSF analysis.
Exactly. MRI is king here. We're looking for those characteristic lesions. They show up as bright spots, hyperintense lesions on T2-weighted images, and the location is critical.
Where do you look for them?
Key areas are around the ventricles, that's periventricular, near the cortex, so cortical or juxtacortical, down in the brainstem and cerebellum, the infratentorial region, and, of course, the spinal cord.
And is there a specific visual pattern that really screams MS on the MRI?
There is. Dawson fingers. On a sagittal view, looking at the brain from the side, you can sometimes see these multiple long, finger-like demyelinating plaques radiating straight outwards from the ventricles. It's a pretty striking and specific finding for MS graft.
Wow, okay. And the lumbar puncture, the spinal tap. How does analyzing the cerebral spinal fluid, the CSF, help?
We're looking for something called oligoclonal bands. These are specific types of antibodies. If we find these bands are present in the patient's CSF, but they are not present in their blood serum.
Meaning they're being made inside the CNS.
Precisely. It confirms there's an isolated immune response happening right there within the central nervous system, and finding these bands is incredibly important for meeting the diagnostic criteria.
Right, which brings us to the official rulebook, the McDonald criteria. You said at the start, the core idea is confirming dissemination in space, DIS, and dissemination in time, DIT.
Correct. DIS means showing evidence of damage in at least 2 different areas of the CNS based on clinical signs or MRI. DIT, dissemination in time, well, traditionally that meant you had to wait.
Wait for what?
Wait for the patient to have a second distinct clinical attack, or wait for a follow-up MRI months later that shows a new lesion appearing, or shows both enhancing active recent and non-enhancing older lesions at the same time.
That could take a while.
It could, but this is where those oligoclonal bands become a real game changer.
They speed things up, like a time warp for diagnosis.
Exactly. According to the latest McDonald criteria, if you find those CSF-specific oligoclonal bands, that alone can satisfy the dissemination in time requirement right away.
So you don't necessarily have to wait for that second attack or later MRI.
Correct. It allows for a much faster confirmation of the diagnosis in many cases, which is obviously better for the patient. You can start treatment sooner.
Okay, diagnosis made. How is MS typically classified? It's not all the same, right?
No, definitely not. The most common type, about 85% at diagnosis, is relapsing-remitting MS, or RMS. Patients have distinct attacks or relapses where symptoms flare up, followed by periods where they recover partially or fully, and things are relatively stable in between.
Okay, relapses and remissions. What else?
Then you have the progressive forms. Primary progressive MS, PPMS, affects maybe 10–15%. Here, there's a steady worsening of neurological function right from the beginning for at least a year without those distinct relapses.
It's a slow decline.
Pretty much. And finally, there's secondary progressive MS, or SPMS. This happens later on in many people who initially had RRMS. They transition from having relapses to having a more steady, gradual worsening of disability, sometimes with or without occasional relapses superimposed.
Got it. Now, before we jump into treatment, a quick but important warning about other possibilities. The differential diagnosis.
Absolute critical. If the clinical picture or the MRI findings don't quite fit the McDonald criteria perfectly, or if you see unusual features like, say, altered mental status, fever, stiff neck suggesting meningitis, multiple cranial nerve problems all at once, or just an isolated spinal cord issue, you have to pause.
And consider what else it could be.
Yes. Think about mimics. Could this be a stroke, a CNS infection like Lyme disease or syphilis, or maybe another autoimmune demyelinating condition like neuromyelitis optica spectrum disorder, NMOSD, which has specific antibody tests now. You rule those out.
Okay, good point. Diagnosis confirmed, mimics ruled out. Let's talk treatment. Two main goals, right? Acute attacks and long-term management.
Exactly. For an acute relapse, if it's causing significant problems like vision loss or major weakness, the goal is to shut down that inflammation quickly. The standard approach is high-dose corticosteroids, often given intravenously for a few days.
And if steroids don't work?
Then the next step is often plasmapheresis, or PLEX. It's basically a procedure to filter the patient's blood plasma to remove the antibodies and other inflammatory factors that are driving the attack.
Okay, that's for the immediate fire. What about the long game, preventing future fires? That's where disease-modifying therapies, the DMTs, come in?
Precisely. DMTs are the cornerstone of long-term MS management. The goal here is twofold. Reduce the frequency and severity of future relapses, and slow down the accumulation of disability over time.
And choosing one sounds complex. Lots of options now.
It is complex. There's a wide range now, and the choice depends on many factors. The type of MS, RRMS versus progressive forms, the drug's effectiveness, its side effect profile, how it's given, injection, pill, 5E, other health conditions the patient has, and importantly, patient preference after a thorough discussion of risks and benefits.
Let's maybe break them down by, say, general type or risk level. You
Yeah.
mentioned injectables first in the outline.
Right, the older guard, perhaps. These are immunomodulators like interferon beta and glatiramer acetate. They've been around a long time. Their main advantage is a generally better long-term safety profile. They're not typically linked with severe opportunistic infections or cancers.
But the downside?
They tend to be less effective at reducing relapse rates compared to some of the newer agents, and they require frequent self-injections, which can be burdensome.
Okay, so moderate efficacy, better safety. Then you have oral options.
Yep. Pills like dimethylfumarate, fingolimod, teriflunomide. These offer more convenience than injections and generally better efficacy than the injectables for many patients. But they come with different monitoring requirements and potential side effects, like effects on liver function or white blood cell counts. Fingolimod, for example, can affect heart rate.
Okay, and then the intravenous options, these are often the heavy hitters, right? More efficacy, but potentially more risk.
That's generally the trade-off, yes. Take netilizumab, an anti-integrin antibody given by IV infusion. It's very effective at preventing relapses, but there's a significant risk.
The PML risk.
Exactly. Progressive multifocal leukoencephalopathy. It's a rare but potentially fatal brain infection caused by the JC virus. Patients must be tested for antibodies to the JC virus before starting netilizumab and monitored closely. If they are JC virus positive, especially with high antibody levels, the risk of PML goes up considerably, making it a much riskier choice. That's a very serious conversation to have.
Definitely puts that risk-benefit calculation into sharp focus.
What about the other IV drug mentioned, ocrelizumab? That targets B cells.
Right. Ocrelizumab is an anti-CD20 antibody. It's also highly effective for relapsing MS. But what makes it really stand out, really unique in the current landscape?
Is its use in progressive MS?
Yes.
Yeah.
It is currently the only DMT approved by the FDA specifically for primary progressive MS, PPMS. Since PPM involves steady decline without distinct relapses, finding something that can slow that progression was a huge unmet need. Ocrelizumab showed it could do that, making it a vital option for those patients.
That's a major advance then. Okay, one last medication mentioned, dalfampridine. This isn't a DMT, right?
Correct. Dalfampridine is purely symptomatic treatment. It's a potassium channel blocker that can help improve nerve signal conduction. Its specific approved use is to improve walking speed in people with MS.
So it helps with the symptom, but doesn't change the underlying disease course. Exactly. It highlights that MS care is really comprehensive. You need the DMTs to tackle the disease process and other treatments to manage the various symptoms patients experience day to day, like fatigue, spasticity, pain, bladder issues, and walking difficulties.
So we've really traced the whole puzzle today, from those first, subtle, sometimes strange symptoms, like Lermite's sign,
The electric shock, yeah.
through the very specific physical exam findings like the Marcus Gunn pupil revealing that hidden nerve damage,
Yank flashlight test doing its detective work.
confirmed by those telltale Dawson fingers on the MRI, all feeding into the McDonald criteria, and finally leading to this complex, tailored treatment plan, always balancing that efficacy versus safety equation.
It's quite a journey, and what this deep dive really underscores, I think, is how the core diagnostic challenge of MS that need to prove dissemination in time, which historically meant waiting, is being tackled head-on by diagnostics.
Like the oligoclonal bands allowing immediate confirmation.
Precisely. The fact that finding those CSF bands can instantly satisfy the DIT criteria is a fundamental shift. It really shortens that uncertain waiting period for so many patients, which leads to perhaps a final thought or question for you, the listener.
Go on.
Well, if CSF analysis can now essentially confirm the time element almost immediately for some, what's the next frontier? How might future diagnostics get even better at confirming the space element, the different locations of damage, perhaps even faster or more definitively than relying on evolving symptoms or waiting for new MRI lesions to appear? How can we shorten that path from first suspicion to confirmed diagnosis even further before the disease has more time to progress?